Okay, so for today, we have two Neuronic consultants presenting. So Will Dixon will present on concussions, TBI, CTE, the pathophysiology of those conditions, and PBM-related research. And then Jordan Hamlin will present a case of a client with a concussion and the PBM protocols that were used and pre and post QEG analysis. And then we'll have Q&A and announcements afterwards. So just a quick bio on Will. He graduated from the University of Edinburgh with a Master's of Science in Psychology of Mental Health and a Bachelor's of Science in Sports Science from Durham University. His academic research was centered around CTE, concussions, and mental health, and he integrates this knowledge with photobiomodulation at Neuronic. And Jordan graduated with a BA in Psychology from Georgia State University. Since then, she's been working as a neurofeedback technician and received her BCIA certification in 2022. And she's also her certified heart math trainer and has been researching the impact of light on the human body since 2020. So I will hand it over to Will now.
Thank you, Brooke. So in the presentation, I want to be going over brain injury and neurotrauma. As I'm sure John will explain later on, the specific client had potential cases of multiple neurotrauma with specific relation to sport. So I'm going to be going over just a brief overview of concussions, traumatic brain injury, and chronic traumatic encephalopathy. We're going into pathophysiology of neurotrauma, and then the PBM mechanisms and some research surrounding PBM and neurotrauma. So I just wanted to show you some of the prevalence within sport so far. I think Mez et al. Kind of signifies this with his finding, with 110 out of 111 ex-NFL players have been diagnosed with CTE post-mortem. And then within mixed martial arts or MMA, 16% of those within a fight have the likelihood of obtaining a concussion. And 50% of those injuries within one fight are sustained to the head. I thought another important research find was Hootman et al. Looked from 1988 to 2014 over sports injuries. And what they found was that women's soccer had the highest risk of a concussion, 0.41 rate per 1,000 athlete exposure, compared to, for instance, men's American football, which is 0.37. I think another important fact from that finding was that men's soccer had a rate of 0.28, which shows the differences between men and women and the impact and the importance of understanding athlete health and the differences within neck structures and neck muscles and how that can be a potential important part to play within head injury. I thought it's once again important to define some neurotrauma related bits of research. So we're going to start off with subconcussions. And this is a type of impact with insufficient force to impact brain function. However, the accumulation or these accumulative subconcussive impacts can lead to physiological changes within the brain, and similar to a concussion in mild TBI. And just for the sake of this presentation, we've clumped it together. You often find that they overlap with one another. But this is when a brain injury occurs and it actually disrupts normal brain function temporarily. And then you move on to moderate to severe TBI, and you see that this is when we're seeing the more significant changes to the brain, where we're seeing long-term cognitive, physical, or emotional impairments. And then finally, chronic traumatic encephalopathy. Once again, a progressive neurodegenerative condition associated with multiple head traumas, often heavily related to sport, and coincides with other neurodegenerative conditions such as Alzheimer's and frontotemporal dementia. Now, when we're looking at head impacts, specifically, there are two motions that can occur. We've got linear motion shown in the top right image, and the rotational motion shown and indicated in the bottom right image. So, and that's just when you have this quick swivel of the neck and the head going from left to right and vice versa. Now, what actually happens within these two motions? Well, what we see is a change in the pressure. From one side, we have this rapid increase in pressure from the skull to the brain called coup, and on the opposite end, we see counter coup, which is a complete drop in pressure, which causes a lag in the brain. And it's the changes in pressures that causes changes in cerebral blood flow, which of course has a major impact on supporting the brain. And then when we delve further into the pathophysiology, what we initially see from the site of injury for the first 3 to 4 days is the increase in cerebral perfusion. And following the 4-day period, we're seeing cerebral perfusion and cerebral glucose metabolism decrease. And then the excitatory neurotransmitter glutamate has a lasting effect on glucose metabolism. And as a consequence, this shunts the glucose away from the mitochondrial pathways. And then this is where you see all the different mechanisms that may negatively impacting cells, such as free radical production, an increase in reactive oxidation in nitrogen species, inevitably inflammation, and as a consequence, of course, impaired mitochondrial function, edema, swelling, DNA damage within the mitochondria, and not only DNA damage within the mitochondria, but also damage within the nuclei DNA. And of course, you've got calcium accumulation that builds up with essentially impacting the permeability of the membrane within the mitochondria, causing the swelling of mitochondria, destroying populations of the mitochondria, and any further surviving mitochondria. Hopefully there's an emphasis on mitochondria. Then moving forward, a persistent TBI or chronic TBI, we're seeing further, once again, neuronal injury, cellular apoptosis or cell death persist, going into structures of white matter degeneration. We're constantly seeing this dysregulation of calcium and calcium ions, disrupting furthermore the mitochondrial subpopulations. And it doesn't just last for several weeks or a month. It's shown to last for months to years. And it's not all doom and gloom. The brain is remarkable, as I'm sure we all know. It does undergo and it can reorganize itself and repair its axons and any damaged cells through synaptic growth as well, synaptogenesis as a healing process. But I think the next slide, or this slide, indicates the severity of just one TBI. And I think this was done by Johnson et al. 2013. These are images of post-mortem cellular sites, and A, B, and C are healthy individuals. The white indicates white matter, and the red blotches indicate white matter degeneration or inflammation. Now, A, B, and C are healthy individuals with no indicator of a TBI, an 18-year-old, a 36-year-old, a 92-year-old, whereas D, E, F, G, and H have all had just one incident of a TBI. But if you look at, for instance, person D, a 23-year-old, 4 weeks post-TBI, you look at the neuroinflammation or the white matter degeneration, you compare that to a 92-year-old or person C with no TBI. You know, if you take the name away, you take the 23-year-old 4 weeks post-TBI away, you take away the start of 92-year-old, and they ask you to identify which one was which, more often than not, you would put 92-year-old with D and the 23-year-old with C. And I think that just shows the impact head trauma can have and the long-lasting impact neurotrauma can have on cellular structures or on the brain. And it's further indicated within F, G, and H with a 43-year-old, 4 years post-TBI, a 67-year-old, 8 months post-TBI, and a 64-year-old, 16 years post-TBI. We're seeing that white matter degeneration persists. It's an ongoing process. It's the cascading effect, and it's severe. Furthermore, let's move on from TBI to CTE. As reported, again, it's a neurological condition associated with repetitive concussions or repetitive TBIs. Prevalent within retired elite athletes, the symptoms heavily resemble, other neurodegenerative conditions like Alzheimer's disease, including memory deficits and mood disturbances. It does, once again, have a widespread degeneration of death of neurons and brain cells. However, it's within the microtubule structures that we will be focusing on within the presentation, specifically tau proteins and microtubule structures. Now, these microtubule structures form the important process of the axons within the neuron, and the tau proteins help form the microtubule structures together. Now, let's say if you had a head injury, you would tend to see the shearing of the axon or the breaking apart, and these tau proteins move off, and usually what you would see is the glymphatic system becoming activated and the tau proteins being moved away as waste products from the lymphatic system. However, multiple TBIs occur, or over time you have multiple TBIs occur, the energy required to essentially recover, repair, and mend these damaged or broken sites becomes unbearable. And therefore you get this buildup of these tau proteins, and they form these NFT or neurofibrillary tangles. And a cascade event happens where these NFTs clump, or the tau proteins clump together, and they hit essentially into other damaged or healthy axonal structures. These structures break apart, and these tau proteins are free floating now. And these tau proteins form NFTs. And it's this cascade event that causes this constant process of neurodegeneration and this constant battle of always trying to fight and repair itself, is inevitably these NFTs, destroy the healthy or damaged axons. And if it starts in the outer cortex, within looking at CTE, and it gets further and further within the limbic structures, such as the amygdala, the hippocampus, and of course it results in brain atrophy. However, in my opinion, there is light at the end of the tunnel. And when I look at research, and when you look at research, you do see the potential benefits of photobiomodulation. Just for instance, changes in nitric oxide levels and growth factor production, increase in cerebral blood flow. We're trying to get the blood flow going, it reducing inflammation, reduction in excitotoxicity. We're stimulating the mitochondria and therefore activating an increase in ATP production through oxidative phosphorylation, and more specifically cytochrome C oxidase. The lymphatic and glymphatic system can be supported, specifically the meningeal lymphatic vessels. We are influencing with PBM reactive oxidation species and induction of various transcription factors. We've seen a reduction in neuronal death, reduction in neuroinflammation, and increased cellular survival. Remarkable, in my opinion. Yes, the research is still early, but what you see is so positive so far. And I know this presentation is heavily surrounded neurotrauma, but it is important, as I'm sure you all know, that PBM doesn't just span one potential condition. We see positive research within osteoporosis, wound healing, muscle problems, inflammatory pain, lung inflammation, stroke, multiple sclerosis, Alzheimer's, anxiety, depression, ADHD, and so on. Long COVID, for instance. But then let's try and swift our heads back to neurotrauma, and we'll look at some animal studies. And I've just picked out 3 that I found really particularly interesting and I wanted to share with you. And I've reported the wavelength, the power, the period of time, and the animals used. But for the first one, for instance, they looked just after 3 days of using PBM on a mouse. They saw a reduction in cell death, potentially through neurogenesis. Then in the second study, what they found within the PBM group, within the non-PBM group, they saw a reduction in the lesion brain injury, 1.4% compared to 12.1% after a 4-hour period of a TBI, which I think is staggering. Then in the last study here, when they compared the PBM group compared to the non-PBM group with the neurological soft signs, they saw no actual changes or no significant changes within the first 24 and 48-hour mark. But what they did see is an improvement following 5 days and a 4-week post-TBI, showing that if you can really support the site as much as you can, you're seeing these longer lasting benefits. And then we go to PBM within human studies. And what you find is the same potential benefits used, such as the first one, Henderson and Morris. Once again, the wavelength, power, all of that's been reported. They saw positive changes within MRI and SPECT scans. They saw decreased depression, anxiety, headaches, insomnia, improved cognition, and quality of life. In the second studies, they saw improved self-awareness, self-monitoring, self-regulation, and social skills and work settings. They saw sleep improvement, reduction in impulsivity, irritation, and anger, mechanisms or symptoms that are heavily associated with multiple TBIs or neurodegenerative conditions. And then here we have in the third study, looking at 4x for 3 younger cases, roughly aged 50 to 60, and in the older case, 74. When they looked at their neuropsychological tests, the 3 younger cases actually improved by 2 standard deviations, and the older case as well improved by 1.5 standard deviation, which is remarkable over this 6-week period. And then after 1 month, they also found significant improvement within PTSD, depression, pain, and sleep. We're seeing the same benefits as well throughout these. And then finally, these last 2 studies as well. Just wanted to highlight once again, of course, different wavelengths and low wavelengths as well. But the results show linear improvements in the Stroop test, specifically executive function and inhibition. The California Verbal Learning Tests improve sleep, fewer PTSD symptoms, and improve social interactions. And then finally, the last study reports increased brain volumes, improved functional connectivity, increased cerebral perfusion, and improved neuropsychological scores. I think these are just some that I picked out that when I looked at these studies, it was quite remarkable, and I enjoyed the reading them. And I think these just show the potential use of PBM on neurotrauma and head injuries. And with that being said, I'll pass it off to Jordan now, who can share a bit more about our case study.
So I am definitely going to present on Gray Maynard because it's always more interesting to maybe hear a celebrity's success story. But I wanted to take a moment to share my own reason for getting involved in photobiomodulation and my own head injury case study. When I was 19, I got 2 concussions pretty close together. And as Will mentioned, having multiple concussions it's quite bad for you, it turns out. I ended up with issues mainly with focus, attention, and even being able to read at different points in time. It was quite alarming to go from being a high functioning person to having these very basic things be difficult for me. It was something that for years I dealt with trying different supplements and diets. I've worked in neurofeedback. I tried pretty much anything you could possibly think of to throw at it. I had improved to the point of, great functioning to anybody else. But one of the issues I struggled with was memory. I was known for constantly writing things on my hands because I would think of something in the moment while I was in my office, but before I could ever get back to my desk, I would forget it. So I'd have to just write things on my hands to be able to make sure I remembered. It was something I had just sort of decided that was going to be my life and I was okay with. I just walked around carrying like a notepad or something with me. And last March, I got my helmet thanks to Austin. He found me on, reached out about this, and I thought, why not? Right? I should try something. I didn't immediately notice the effects myself, but I started interacting with my friends and I was constantly being told, oh my gosh, your memory is so great. And I was like, wow, thanks. You're just probably making fun of me or something. But I kept hearing it again and again and again. And I started paying more attention that I wasn't having to write things down. I was remembering things. I was, in fact, keeping many different tasks in mind. And this was after maybe 3 months of use. So I got really excited about the potential of this because this was something for so many years, over a decade, I had just dealt with having poor memory and thought that that was my life moving forward. So this significant change has just absolutely made me fall in love. I was already researching light therapy prior to that. I started researching light therapy back in 2020, but hadn't had my own experience with infrared light. So this helmet is quite important to me, and I am so thrilled to be able to work with Neuronic now and to bring you this awesome case study of somebody who is famous and quite interesting. So I'll present now on Gray Maynard. He was a UFC fighter. He competed in the lightweight and featherweight division. As you can imagine, he got quite a few of those lateral and rotational hits to the head. And as Will had mentioned, those add up over time. He really struggled primarily with attention and focus. Other things that he had noted were night sweats, mood swings, obsessive thoughts, impulsivity, and compulsive behavior. after we started working with him. This is the first initial protocol. This is not based on his quantitative EEG. He hadn't had one at this point. So just based off of his symptoms, his first protocol he was given was 6 minutes of glow globally and 6 minutes of 40 hertz at 75%, again, globally. This was just to hopefully address those attention and focus issues, but this was, you know, just a standard protocol, not tailored in any way. After he started using the helmet, he received a quantitative EEG in October of 2023. I will come back to these at the end, so I'll have the pre and post put together, but here's your initial image. You can see it's not very active. There's a lot of underactivation going on here, and something you might assume from a person who's had repeated head injuries over time, that there might be some neurodegeneration that's going on. He's in his 40s, so this is a particularly low voltage reading. After this cue, we changed his protocol to be 9 minutes at 100%, that glow protocol again globally, and then 6 minutes at 12 hertz, 75%. He was seeing some improvements, but nothing notable at this point. He had another quantitative EEG done in February. So this is now 4 months after this protocol. And I think there's some pretty intriguing things, but at least just looking at it off the bat, there's some improvements. It's starting to increase in some of the voltage and maybe some more connections. So his third protocol based on this post-QEEG was 10 minutes of glow and 10 minutes of 10 hertz, since he had that quite low alpha at 75%. So I'll put up the pre and post, but we had a follow-up interview with him, and he noted that he had an easier time sitting down to read a book. He had increased productivity in completing computer tasks, so both being able to sit down and then attend to the task and complete it. And he noted that his Garmin sleep score improved. And the Garmin sleep score is based on sleep duration, the average stress score during sleep, total deep sleep, total light sleep, total REM sleep, awake time, restlessness, and heart rate variability. So quite a few factors to be able to improve that score. And he said it was fairly consistent. So looking at these before and afters, I think that there's some pretty interesting things. First, I note that his delta absolute power has increased to be in the more normalized range. Increasing this power is something that at least most of us probably assume is not something you can consciously do. So seeing this increase in power is pretty interesting. One, I would assume if he's getting better sleep, hopefully that's improving things. But two, there's a chance that there's an increased activity that's occurring. Having that increase in the delta power can help improve things like sustaining attention and focus with it, as well as the theta too has also increased in its power. Things that we don't normally maybe think about, but it can be helpful for attention, working memory, and encoding memory as well. I think that it's interesting and something that we definitely can't know for sure, but I hypothesize with this hypercoherence that we see now in the post-QEEG. I think there's a chance that it's saying that there's more neurogenesis, like Will had brought up in this. Of course, we don't know. They think the only way we could have known is like diffuse tensor imaging, which we don't have, or if we cut him open, which we can't. But I think it's pretty interesting because this type of shift isn't something that we should see outside of infancy. So I think it's a promising thing. While his report is just that increased ability to attend, I'm hoping that the longer he continues using this helmet, the better that all of these symptoms will get, and the more things he might consciously notice. Since the improvements are mostly in that delta and theta range, those are more subconscious waves, so I wouldn't necessarily think that it would be something you would miraculously notice, but hopefully over time, those changes would continue to improve his quality of life. So I'll be curious to see what his next one is. So that is it for our presentation, and we'll open it up for questions.
Hey, John, I don't know if you're waving or you have a question.
Oh, no. Fair point. Thanks for inviting me, guys. Great presentations, both of you. Thank you both so much. I have lots of questions. Number one, can I get a slide deck, Will?
Yes, I'll also, if you want, I'll send over all the references.
Because I'd love the slide. I mean, you have some glorious, slides there. And frankly, obviously, I'll give you credit for them, but I would love to be able to use them to show people, because I got a lot of people interested in this, but none of them know the science. And frankly, I can't explain it well enough. And you can. I got a question about, I'm using this clinically, and we're doing Neuronic before neurofeedback. Pretty classic approach. Is twice a week for 10 minutes enough to move anybody's needle? Truthfully, I'm trying to figure out, I've seen presentations. Roger Lee had one with somewhat, kid with autism. Well, after 3 sessions was speaking, and I'm like, what? So I'm hesitant to say out loud, oh yeah, this is really going to change your life dramatically, doing this for 5 or 10 minutes a couple of times a week. What's the coherent wisdom here from the group?
I think we've seen individuals use it at least 3 times a week in a clinician and report benefits. And, some of the studies there that I've discussed as well, they've used it maybe 3 times a week as well. I think the more, the better potentially.
Of course.
But I think that's everyone's opinion, at least in Neuronic. But we have seen some cases, or we talk with clinicians who just use 3 times a week potentially on their clients.
Because I'm working on a model of having a rentable unit here. I mean, that's the ideal. So people can take this home and use it literally every day for a month. And I think after a month, you're going to start to see really amazing shifts. But I'm hesitant to pull that trigger. Obviously, it's a lot of money if I want to buy 4 or 5 of these things. So I have to be pretty confident that people are going to think that this is going to help them for some sum. That was one of my questions. Nonverbal learning disability. I've got a client who came to us. Alyssa's nodding her head. Maybe you can help. This is new to me. I mean, I suspect a lot of my clients have nonverbal learning disability, whatever that may mean. And I'm looking for, has there been any studies done on this sort of vague diagnosis? I know it's not a well-honored diagnosis, to be frank. It's the inability of the client to read nonverbal cueing. She's super smart, graduated college, valedictorian, summa cum laude. So she's got strong compensatory skills, but she's missing this certain element. And what should I think about targeting? That's one part of the question. And the other part is sort of pre and post testing. What do you guys favor in terms of, I see a various list. I wrote a few of them down, GCS. I don't even know what that is. I'm not sure what NSS score is. There's a bunch of things in here that I'm not even certain what they are, and I don't do them. So I have to outsource this somehow. What is the sort of current standard for pre and post analysis on improvement in cognitive function?
I can share something that I learned more recently. So I obviously work more on the client end of things. I deal with support related things. So I'm not 100% involved in everything, but I do talk to a lot of people that are purchasing the device and using it. And we've been recently working with someone who at this point has not obtained a QEEG. So I can't say anything about that. But though they did report, I believe they were mostly using a combination of Glow and then also, I believe, Focus or Energize. I would have to triple check everything. I talk to a lot of people, so I sometimes forget, but they reported that their husband, who's had Alzheimer's and who's gone completely nonverbal for years, is starting to not necessarily speak, but starting to want to speak. She says she's noticed that he's actually trying to say things versus before it was just completely nothing. I know I don't have a QEEG or anything, but hearing things like that gives me a lot of hope. Honestly, just people who are, using it on themselves and their loved ones at home, and they are interested, they're going to be getting a QEEG and stuff as well. So I'm very interested to keep following that as well. But I just thought it was a really interesting story, and just, I don't know, it's just a nice thing to hear,
Personally, I don't have anything specific to measure with nonverbal learning, but I like to use the CNS sensitivity score. I think that's just a good indicator of where to start someone off with the device. How much, energy do we want to give them to begin with? But I'm not sure. I don't know if Maria, you might have some metrics that you might prefer. I'm not too sure. I don't know.
For verbal issues, unfortunately, nothing comes to my mind. I don't know, perhaps Wes, you have your hand raised.
So for our neurocognitive and neurodegenerative disorders, we'll either use the microcog, which is a computer-administered test. It used to be considered one of the gold standards for memory testing, and now there's some others. It's much shorter than doing something like the Lurie in Nebraska or Right-Hand Halstead. So, and the computer administers it and scores it almost immediately. So there's a benefit to using that one. And we do that with our neurodegenerative patients. As far as QEEG markers in the population goes, the relative power seems to be more sensitive to changes than absolute power. And again, without looking at the raw EEG, it would really be difficult to say, Jordan, whether or not we could say much about those maps that you showed, because the coherence would be suggestive of artifact given at those locations. However, the relative power is as subject to that, and so it might have been a better marker. And actually, in the maps you showed much more change in terms of relative power. And it may be that when we're doing serial cues on these folks, that the better, more stable marker over the course of training and treatment would be relative power, particularly in that population. PBIs is kind of like our sweet spot as a company, and so we've done tons of work with that. We're amassing a pretty big database of mild traumatic brain injury, and so our preliminary results are telling us, in answer to John's other question, that 2 to 3 times per day with a maximum dose of 60 minutes administered over the course of 90 days produces a more stable result than any other dose rate. And again, that's very preliminary, anecdotal at this point. We're still collecting data. And it may be difficult for us to publish because the patients that are acquiring the helmets are doing it through the same company that's doing their assessment, and it is for personal injury forensic cases. And so we might have a little bit of a problem publishing what we're finding. So, but that's what it's looking like on the TBI front. And again, this is very specific to mild traumatic brain injury for folks involved in motor vehicle accidents, mostly, some slip and falls. And in many cases, they've got secondary PTSD to their motor vehicle accidents, which is also quite common. So it may be that our data is only valid for that, population, and, the forensic PI, TBI population, that may be so narrow that it's not of much use to anybody else. But that's our current best understanding of what's going on.
Wes, you may be the right person. You may be the right person. Sorry, just a quick one. Is there any data on the subconcussive reality? I think that's probably most of our clients, are going to have unacknowledged TBI experiences in their lives. It's always a shock to them to point out whatever, that they've had these, and they go, what? Oh, that's a thing? Okay, yes, it's a thing. Is there any quantitative observation about how many of those subconcussive events would lead to a more serious problem?
Yeah, the short answer is no. My buddy Daniel Amen has been studying this for quite a while, investigating SPECT, and some of his folks will actually go through and do neurofeedback with Jay Gaddis at the Costa Mesa Clinic, and there's another one that does it at the Atlanta Clinic, and I think there may also be one at the New York Clinic, but their data is so sparse and spread out because only a small N relative to the number of the folks that come through the clinic get QEEGs, that it would be difficult to say. The sports industry has been tracking this for quite some time. The Rockefeller Neuroscience Institute at West Virginia University has got a pretty good database on it between the military, because DOD and VA both contract with Rockefeller to research subconcussive forces and TBIs, mainly in the area of dynamic overpressure from blast trauma. but also from, when you're in the military. I'm a retired Marine, so I know we use our heads for more than thinking, and so that you get a lot of shots to the noggin. And of course, Marines tend to use their heads for everything other than thinking, and so we tend to get more TBIs than the others. There's also a higher incidence of ADHD in the Marine Corps than there is the other services, but on the whole, if you aggregate all the services, the instance of ADHD amongst the serving population is the highest in the military of any profession. And believe it or not, ADHD is highest among pilots, fighter pilots in particular, across all the services. And that's something that we don't very well understand, and that is what's the adaptive aspects of ADHD. And one of them is rapid task shifting, which comes in really handy in the cockpit of a fighter. So we've looked at subconcussive traumas, and there isn't a threshold. There's so many variables that go into it, that premorbid conditions that go into it. Education seems to be an insulator. Overall health does. There's some race ethnicity things, body fat, android fat, gynoid fat percentages, water weight. If you're dehydrated when you get a subconcussive trauma, you're more likely to suffer an after effect than if you're hydrated. There's all of these things that play into it, probably so many so that we may not ever be able to nail this one down. And I mean, brain trauma, TBIs has been my life here the last 15 years. And the more we try to squeeze it, it's just like trying to squeeze on any other gelatinous material. It just goes through your fingers.
Love the metaphor. That was perfect. And why, by the way, Will, why has no one filmed a skull doing the rotational impact thing? The back and forth thing is great, but you are unfortunately relegated to saying, and there's another one which I can't show you in 3D.
Well, it actually has been modeled in 3D.
Get a copy of Will for his day.
Oh, Wes, I would have loved to have you sent that over to me, please. A bit late now, but at least for John when he wants the slide deck.
Yeah, so both DARPA and Spay Wars in Charleston have modeled that. And they did animal studies first, and then they did it using multisensorial helmets with the fighter pilots. Spay Wars did the fighter pilots, and DARPA did the black stuff that DARPA does. But by the way, DARPA's given us some great things in the realm of TDCS. If you look at the TDCS protocols, most of those come from DARPA. The Defense Advanced Research Projects Agency. It used to belong to the Army, and now it's all services. But they've done tons of good things as well as some nefarious things.
Thank you, Wes. I was just going to get to Andrew and Patricia have their hands raised, but John, if you were no? Okay, Andrew, how about you go ahead with your question?
Thanks. Just a couple quick comments. Mike Loosemore, Professor Mike Loosemore, in the UK, head of British Sport. He's also modeled in real time concussive injury. He's got a device, a bite guard now, that in real time models it maps the trajectories of impact and force right to a computer on the side of the field, and models the concussion as it's gone through the brain and predicts the after effects in terms of should they be out of play or not. So that's definitely in the landscape of this stuff. John, your question about nonverbal learning, HEG makes massive impacts there. So I'm thinking we're doing the same neurovascular coupling thing with PBM that we're doing with HEG, because we see the same stuff Jordan showed with that shift of both coherence and the delta going from hypo to hyper, super common in healing from a brain injury, either a concussion injury from a car accident or repetitive. I work with athletes who get injured every season, and they just keep going back. And you see the same phenomena again of excessive and then a dearth and then back and forth as the coherence changes, as the brain heals out, so to speak. And the phenomenology changes. Like your client probably has way less OCD, but I bet he has word finding issues. His reaction time's not yet where it needs to be. And you'll see that in the speeds, the synchronization of the peak frequencies, more than you'll see it in the amplitudes or the power. So I have a hunch that we're going to get into this neurovascular coupling thing, the lymphatic stuff that was mentioned earlier. I think we're going to be in that landscape with some of our deepest findings, but I don't know if we know how to image that stuff beyond SPECT. Oh, and as an aside, Peak Brain's doing all the QEEGs now and a lot of the neurofeedback across the AMIN network. So we are recording lots of brain maps from AMIN client base, FYI. And any AMIN doctor that has clients who have the need for QEEG has access to QEEGs. For those who don't know, I own Peak Brain, which has offices, there's 4 in the US, a couple overseas. We've really reduced QEEG rates, making it membership driven. So clients pay $250 once a year for unlimited access to data, which helps the Neuronic population grab data if they want to do protocols. We're going to start doing that soon in-house. But it also helps AMIN grab QEEGs for their clients when they want to use data. So if you need data in New York City or St. Louis, Southern California, Sweden, London, you just say the word. So I couldn't let the fact that AMIN's doing a little bit more these days sort of through us with QEEG and neurofeedback than you might expect.
Thanks.
All right, that's all I had to say, I think. Thanks.
Thank you so much. Patricia, you've got your hand up.
Yeah, basically over the years when I was doing neurofeedback, this is not with the Neuronic because I've only been, that's still new to me. But what I noticed with clients who had concussion was under your rubric of impulsivity was really outbursts of anger. And that's real specific. And that seems to be that's one of the things that I went after in terms of doing neurofeedback training was specifically I used F4 a lot, seemed to really calm that system down. But I think impulsivity is too broad a category if you're going to use it for, because I think that kind of outbursts, and of course I tend to use frequency, magnitude, and duration as one of my main, if I'm not using test data, but I'm looking at specific events, how many, what kind of magnitude they have on a scale of 1 to 10, and how long a duration that episode lasts. Because at least gives me something if I don't have specific test data, if that makes, well, I mean, my system actually gave me a graph of every session. So that really helped me determine a lot of things, particularly when I done a lot of gamma training. So just FYI.
Thank you, Patricia. Any other questions? If not, I was going to move on to a few announcements. But first, I want to thank you, Will and Jordan, we just really appreciate you sharing all your experiences and the time that you invested reviewing all the different types of neurotrauma and the related research on PBM. And Jordan, sharing your own experience and Gray's story. And thank you, John, Wes, and Andrew, and Patricia for piping in and contributing all your knowledge. So Maria had a quick announcement about a job opening in the research department.
Yes. Hey, everyone. So yeah, I would like to announce that we're looking for someone to join our research team and consultation team to help supervise and design our internal studies. So basically their responsibilities would be to help designing studies, ensuring that they meet the scientific and ethical standards, and being the go-to person for like overviewing these internal studies, and that they can act as the PI for such studies, and just making sure that everything is ethical and compliant. So we're looking for someone who has experience with managing clinical trials and knowledge in GCP standards, as well as graduate training and knowledge on scientific methods and standards, with an educational background in either psychology, neuroscience, or a related discipline. We haven't posted a job description yet on like recruitment platforms such as LinkedIn yet, as we would prefer to find someone with a referral or a contact from this excellent network that we have of clinicians and professionals. So I'll have the job description sent over on our email following up from the clinician rounds. And if you know of anyone or that may be interested, to email me at maria.dacosta@neuronic.online. But I'll have, as I said, all the details in our follow-up email.
Thank you, Maria. Any other questions? Nope. Okay.
I have a real quick question. Andrew, do we have your contact information about Peak Brain?
Sure. Yeah, Peak Brain Institute is the website, but yeah, it's just Dr. Hill, DRHILL at peakbraininstitute.com or peakbrainla.com also works. It's all kind of the same domain. And if you Google me, I'm a podcast, I get around. So you can find me really easily on the internet if you need to. So
Thank you.
He's also on our QEG provider map on the Neuronic website too.
All helpful. Thank you.
Perfect.
I was
Thank you guys so much. Oh, Patricia.
Well, if you have time, I don't know if anybody wants to be bothered with this, but this is so relevant to a new client that I just did an intake with in a couple of sessions, who's had multiple concussions, when he says, and I believe that, and plus cervical surgeries that has rendered this man. Well, that's the reason why I said the question about this impulsive, but he calls it defensive. My sense is it's an overarousal level that's way greater than the other person who's receiving this expects, so that it comes off as being very intimidating. And so, I mean, now that I don't have my neurofeedback clinic, I feel kind of lost, and so I do have beginning information with the Neuronic. And so I was thinking that this might really be a good thing to begin to soothe this brain a little bit more, even if it's been a long time. Am I correct in that assumption?
I think it'd be interesting what Wes was saying about the maximum of, was it 60 minutes that you were seeing? A maximum of 60 minutes. So a couple of times a day to try. That sounds promising, although we've seen results with clients with less than that, but that particular client you've just described sounds quite complicated.
Just using glow as a, just as a beginning is what you're talking about?
That's what we usually do.
And
yes.
it has its own time limit, doesn't it?
It does. It stops off after 10 minutes.
But do you start out with a lower level to see how they tolerate it?
Yes, and we'll go.
Yeah, no, all I was going to say, Patricia, is sometimes if you give them some sort of sensitivity score, CNS sensitivity score, and they score quite highly on that, extremely sensitive to, light and sound,
Right.
you may want to start off with a lighter setting. And that might be, through the custom program for, I don't know, could be, for instance, 2 minutes
Gotcha.
with the intensity, well, at 50% or 25%, or you could have it like glow at 100%. Yeah, but I think sometimes using some sort of sensitivity score might be the way to, find that sweet spot to begin with and then develop from there.
Well, he is going to get a cue. I will be giving him a cue.
Oh, okay.
So that will, at least I'll have something to start from as well. Okay, but this is very intriguing because I certainly would like to see him get better, because he's very distressed about his situation. In any case, thank you very much. I appreciate your input.
Thank you, Patricia. And I think what Will just said about the sensitivity, we have found that is a really good marker for how low to start the dose.
Well, I'm sorry, I missed, what is the sensitivity test that you give them other than the cue?
We would be all right to send over.
Yeah, we can send you a copy of the
would
form.
you?
It's like an intake form that just
I
asks
would
questions
appreciate
about if you're sensitive to pharmaceuticals or light, sound.
Gotcha. Of course. I mean, I have to be reminded about all of these things. After all, the hard drive up there seems to get overloaded. Okay, but thank you. Please do.
You're welcome. All right. Well, thank you so much, everyone. Really appreciate it. And the next meeting will be June 6th. And we will hopefully see you all back then. Happy Thursday.